Good morning, everyone. It's 8 a.m. Pacific time, so we'll go ahead and get started. So I'd like to welcome everybody to today's RPS GlomCon session on membranous lupus nephropathy. And it's my pleasure to welcome Dr. Tiffany Caza. Dr. Caza is a kidney pathologist at Arkana Laboratories. She's originally from New York and completed her MD, PhD, and anatomic/clinical pathology residency training at SUNY Upstate Medical University. Her research interests are in autoimmune kidney disease, including membranous nephropathy, lupus nephritis, and anti-brush border antibody disease. She also enjoys teaching, creating free open access medical education with the Nephrology Social Media Collective, painting, and spending time with family. And so thank you, Dr. Caza, and I pass it on to you.
Thank you for that introduction. So I'm going to share my screen. Is everything good? And can you all hear me?
Can hear you, but we can't see your screen just yet.
All right, let's try again. How's that?
Yes, there we go.
Okay. All right, so thank you for the opportunity to speak at GlomCon. I really enjoy GlomCon and I'm here almost every Sunday. So it's a pleasure to participate today. And so I'm going to talk about membranous lupus nephritis. And lupus nephritis overall has a very high disease burden in patients with systemic lupus erythematosus. Lupus nephritis affects about 50% of lupus patients, disproportionately affecting those of minority populations, including Hispanic and Black individuals. It typically presents as hematuria and proteinuria on urinalysis, or may present with acute kidney injury, frequently with concurrent nephritic or nephrotic syndrome. Over time, lupus flares can lead to chronic kidney disease, and progressive and recurrent activity can result in end-stage kidney disease. And approximately 10% of patients with membranous lupus nephritis, and up to about 30% for those that have a proliferative component, will go on to end-stage kidney disease. And lupus nephritis could be one of the first manifestations of systemic lupus erythematosus, and the patient may not already have a diagnosis of lupus. So it's important to keep on your radar. When you diagnose a kidney biopsy that has membranous nephropathy or a proliferative immune complex glomerulonephritis in a young woman with a positive ANA, consider lupus. And the SLE Disease Collaborating Clinics has a point system for diagnosis of lupus, wherein a patient with a positive ANA, 10 points of multiple systemic domains could give you a diagnosis of lupus. And if you look down to the renal domain, having membranous lupus nephritis is 8 out of the 10 points, with a proliferative lupus nephritis being 10 of 10 points. So it is something definitely to keep on mind when you have a diagnosis of membranous or proliferative glomerulonephritis on a kidney biopsy. The classification of lupus nephritis is established by the International Society of Nephrology and Renal Pathology Society classification system. There are 6 classes. And the first is minimal mesangial lupus nephritis. So there is presence of mesangial immune deposits without evidence of proliferative activity. In mesangial proliferative glomerulonephritis, class 2 disease, there is some mesangial hypercellularity without other proliferative changes or significant numbers of subepithelial immune deposits. Class 3 and class 4 are focal or diffuse lupus nephritis. These contain proliferative glomerular lesions, and we'll go into these next. And then membranous lupus nephritis has an appearance of membranous nephropathy on biopsy with some thickened glomerular capillary loops with corresponding subepithelial IgG deposition within glomeruli. And membranous lupus nephritis can occur in concurrent with proliferative lupus nephritis, so either class 3 or class 4 disease. If there are greater than 50% subepithelial electron-dense deposits along the glomerular capillary loop, it would be consistent with a concurrent membranous component in a patient with proliferative lupus nephritis. If there's less than 50%, we don't call a concurrent membranous component as you can have subepithelial immune deposition in the setting of a proliferative lupus nephritis. And having a proliferative component will result in poor outcomes. These are scored on a kidney biopsy by the NIH activity and chronicity indices. And the lesions include endocapillary hypercellularity. So here's a Jones-Silver stain of a glomerulus, and you can see the glomerular capillary loops are occluded by mononuclear cells, or neutrophils. And neutrophils is actually a different component of endocapillary hypercellularity included in the activity or chronicity index. Fibrinoid necrosis and crescent formation are two of the most destructive glomerular lesions. On a Jones-Silver stain, we can see disruption of the glomerular capillary tuft with extravasated fibrin and a cellular crescent. Fibrocellular crescents would also be considered as active glomerular lesions. Wire loops and hyaline thrombi are other evidence of activity. And wire loops within glomeruli, where we have these massively thickened glomerular basement membranes, are due to the presence of subendothelial immune deposits. You can also have hyaline thrombi that we typically see in cryoglobulinemic glomerulonephritis as well. And so overall, with activity, we have the endocapillary hypercellularity, neutrophils or karyorrhexis, of which it will be endocapillary, fibrinoid necrosis, crescents, wire loops and hyaline thrombi, and also interstitial inflammation. So 21 of these 24 points comes from glomerular lesions, although interstitial inflammation is known to result in poorer outcomes in lupus, although is not really well represented in the activity index. And chronicity indices include what we typically look for on a kidney biopsy: the percent global glomerulosclerosis, presence of interstitial fibrosis and tubular atrophy, and atypical segmental sclerosis in the form of fibrous crescents. And so here's an algorithm for diagnosis of lupus nephritis. If you have immune complex deposits in glomeruli, and there's greater than 90% global glomerulosclerosis. So this is really an end-stage kidney that has immune deposits. This is a diffuse sclerosing lupus nephritis, or class 6. If there's less than 90% chronicity, which hopefully occurs in the vast majority of cases, when there are immune deposits present within the mesangium and largely restricted to the mesangium, if there is no mesangial hypercellularity, this would be a minimal mesangial lupus nephritis. If mesangial hypercellularity is present, this is consistent with a mesangial proliferative lupus nephritis. If there are subendothelial deposits in addition to mesangial deposits, these typically are associated with proliferative glomerular lesions. And if less than 50% of glomeruli are involved, or it's a focal process, we have focal lupus nephritis. If more than 50% are involved, this is seen in a diffuse lupus nephritis. When there is a predominance of subepithelial and intramembranous electron-dense deposits, of which frequently will have mesangial deposits as well, this is membranous lupus nephritis, and we'll focus on this from here on out. So overall, lupus is a very heterogeneous disease, not only in the kidney, but within multiple organ systems. Patterns on a biopsy can be relatively nonspecific in membranous lupus nephritis and look a lot like primary membranous glomerulopathy. Here's a case of membranous lupus nephritis where you can see the glomerulus on a PAS stain has prominent capillary loops, of which contain frequent formation of holes and spikes on silver stain, corresponding to basement membranes having the presence of immune deposits. By immunofluorescence, there is granular staining for IgG along the glomerular basement membranes and within the mesangium. And overall, that really has a similar, if not identical, appearance to primary membranous glomerulopathy. So here are some clues that might help us distinguish from a membranous lupus nephritis from membranous nephropathy that could be idiopathic. When there is full house staining on a kidney biopsy, so showing the 3 immunoglobulin heavy chains, IgA, IgG, and IgM, and the 2 complement components, C3 and C1q, is seen in autoimmune diseases, particularly systemic lupus erythematosus. You may not have all of these together, but frequently C1q is fairly specific for autoimmune disease. There may be a tissue ANA reaction, and that is when we see the tubular epithelial cell nuclei and frequently also podocyte nuclei staining brightly for IgG. In addition to tissue ANA reaction, other extraglomerular staining can include tubular basement membrane deposits, which are granular in character. Here they are nearly confluent, but have some granular composition to them, which we can see ultrastructurally with this proximal tubule studded with immune deposits. Mesangial immune deposits are almost ubiquitously seen in membranous lupus nephritis cases. By electron microscopy, we have subepithelial and intramembranous electron-dense deposits, as well as mesangial immune deposits. Frequently in lupus, there may also be the presence of tubular reticular inclusions, and these are seen on the subendothelial surface of the glomerular basement membranes. These are considered as interferon footprints, and in addition to lupus, they are seen in other interferon-driven states, such as HIV infection, SARS-CoV-2 infection, among others. And this finding has fairly low sensitivity on a kidney biopsy as well. You sometimes really have to search for them and may not always be found in a glomerulus. To distinguish membranous lupus nephritis from membranous nephropathy, IgG subclasses could also be performed, although I don't think in most cases they would be necessary. But you can see reaction against multiple IgG subtypes. In idiopathic membranous nephropathy, typically there is IgG4 predominance, or sometimes IgG1 and IgG4 predominance. In lupus, you may have reactivity for all 4 subtypes, or typically more than just IgG4. And so this is a study from Columbia University that looked at the sensitivity and specificity of these findings in lupus nephritis. So if there was intense C1q staining or full house immunofluorescence on a kidney biopsy, presence of extraglomerular deposits, such as tubular basement membrane deposits, but also could include vascular immune deposits, having subendothelial in addition to subepithelial deposits, or presence of tubular reticular inclusions are all characteristic features of lupus. If you have all 5 of these, there's a 99% chance that that biopsy represents lupus nephritis. And even if there's only 3 out of the 5, that's a 95% chance. So it's something to keep in mind as you review kidney biopsies and are looking for a potential etiology. So in idiopathic membranous nephropathy, particularly in the last few years, there's been an explosion of antigenic discovery of what are the causative targets of disease. The most common in idiopathic membranous is the phospholipase A2 receptor, or PLA2R, although multiple other antigens have been described to date. Overall, the knowledge gap of primary membranous nephropathy is less than 1/4 of cases, probably close to 15% of cases. But in the setting of membranous lupus nephritis, PLA2R positivity is much less, about 3 to 5% of total cases. And there have only been 3 other antigens described to date, and there are many that are yet to be discovered. So we have a huge knowledge gap here, and a lot of room for discovery, as well as a need for discovery. And one reason for a need to discovery is currently within the algorithm of managing lupus nephritis, repeat kidney biopsies are frequently needed. Although practice can vary between groups, but if you have a non-invasive biomarker to monitor disease, such as the presence of antibodies specific to that type of lupus in the serum. This could be helpful for therapeutic monitoring, similar to what is done for PLA2R positive membranous nephropathy, where antibodies are known to increase with disease activity, fall prior to remission, and be used for treatment monitoring and to identify recurrences. So how do we find antigenic targets of disease? There are several approaches. One is through serum immunoprecipitation with human glomerular extract, followed by mass spectrometry for identification. This was used for the discovery of PLA2R and TGFBR3-Associated MN, among other antigens, but the protein targets need to be expressed in glomeruli for the serum to react with human glomerular extract. So if there are circulating immune complexes or in situ immune complex formation, it may not be seen. Most recently, tissue-based approaches have been employed to get around this issue. Laser capture microdissection or protein G immunoprecipitation can be used for protein discovery. And serum immunoprecipitation with glomerular extract takes sieved glomeruli from a kidney for which a protein lysate is made. Serum is reacted and run into an SDS pH gel. And a corresponding band is cut out, undergoes tryptic digestion, and mass spectrometry will be employed to identify the targets. And this method was used for the discovery of multiple membranous antigens. In addition to the earlier antigens of PLA2R and TGFBR3-Associated, newer antigens, HTRA1, Netrin G1, Contactin-1 were also identified through this technique. Laser capture microdissection for antigen identification employs the FFPE tissue. You take thick 10-micron sections and cut them under a laser capture microdissection scope. You remove the glomeruli and do tryptic digestion into peptides and mass spectrometry. This technique is going to enrich for all proteins within the glomerulus. It will not just be the immune complex, the target of the immune complex of interest, although they should be enriched if they are abundantly seen in subepithelial deposits. Another method is to elute immune complexes from the frozen biopsy tissue. So you can take the residual frozen tissue core, produce a protein lysate, and react against protein G. And protein G binds immunoglobulins and can pull them out of biopsy tissue, followed by tryptic digestion into peptides and identification of those targets of those immune complexes. So some steps in working up a new antigen is that you enrich or extract for the immune complexes, perform mass spectrometry for protein identification. Then you want to perform immunostaining for the target antigen to see that there is the same pattern of staining as IgG within glomeruli, and then confirm there's actually co-localization with IgG. Other studies that can be useful for further characterization include serologic studies to determine that there are circulating antibodies in patients with this new type of membranous, determining the antigenic frequency, so how common are these new antigens in membranous, and doing a clinical and pathologic review for a larger cohort to see, are there disease associations that could be identified? So I'm going to give an example. This is an example outside of membranous lupus nephritis, but of primary membranous nephropathy. And we'll use NEL1, or neural epidermal growth factor like 1. This is likely the second most common antigen in idiopathic membranous. And as a disclosure, I'm going to show our own data here from Arkana, but NEL1 was first described by Dr. Sethi and Dr. Ronco back in 2019. So protein G immunoprecipitation was utilized to elute immune complexes from this case. And here is a volcano plot. So as you go up the y-axis, you have a lower p-value, to the x-axis, there'll be a higher fold change. So up in the right-hand corner should be our protein of interest, in this case, NEL1. When staining, there was a granular capillary loop staining within glomeruli for NEL1. Co-localization with IgG is present, but not present in other forms of membranous nephropathy. So here is that same case by mass spectrometry, showing co-localization of IgG with NEL1, but not seen in a PLA2R positive membranous case. To determine the antigenic frequency, we stained for 6 months of membranous nephropathy biopsies. It was about 200 cases. Perform NEL1 staining by paraffin immunofluorescence, although you can use immunohistochemical staining or another method. And about 5% of membranous cases were found to be NEL1 positive. Disease associations were established from different cohorts. Patients were found to be of older age than you see with idiopathic membranous, about 10 years older. 1/3 of patients had a history of malignancy, and 14% had a history of lipoic acid supplementation use, which is an association that was identified by Dr. Spain's group. And this is an over-the-counter supplement, so it may be something that's not even in the patient's medical record. Next, we examine for antibodies present in patient serum. So you can take a recombinant protein of the antigen of interest, in this case NEL1, incubate with patient sera, and it identified a band of similar molecular weight. So the patient sera serves as a primary antibody with an anti-human IgG HRP as a secondary antibody. And you have to establish specificity. So in this case, there's no staining in PLA2R positive membranous cases. Another method that can be used, as well as other potential methods, are to overexpress the protein of interest in a cell line. HEK293 cells are frequently used. Other cell types can also be utilized. So here we have NEL1 overexpression in an HEK293 cell line with reactivity against a primary antibody, but not the empty vector of the cell line itself. When reacting patient serum, there is positivity that's not seen in the empty vector or the cell line itself. And this was specific, not seen in other types of membranous. And so the reason we want to determine the antigen is hopefully this will provide a biomarker to follow disease activity, whether that be through ELISA, indirect immunofluorescence assay, or another method. And so here are some new kids on the block. These are antigens that have been recently described in the setting of membranous associated with autoimmune disease, with the first 3 being pretty frequent in membranous lupus nephritis. Contactin-1 here, CNTN1, is not really associated with membranous lupus nephritis, but it is with a unique autoimmune state, chronic inflammatory demyelinating polyneuropathy patients. So EXT1, EXT2-associated membranous was described by Dr. Sethi and Dr. Ronco's group. This was the first antigen that was identified by a tissue-based technique. That technique was through laser capture microdissection. So here is some scaffold sequence data from multiple patient cases identifying a high peptide count for EXT1 and EXT2 in patients with membranous nephropathy. Then staining is done for that potential antigen, and EXT1 and EXT2 both stained within glomeruli in a very similar pattern and was not seen in a control case. So here's a EXT1, EXT2 negative case. EXT1 and EXT2 patient sera were found not to react against EXT1 or EXT2 recombinant proteins or a heterodimer thereof. And so we can see the protein run in a gel with reactivity with primary antibodies, but not patient sera. This was true with both reducing and non-reducing conditions. And to date, other groups have examined for EXT1 and EXT2 antibodies, but these have not yet been described, at least not in the literature yet, for membranous lupus nephritis. However, we do believe that there is a true antigen-antibody interaction, and that this does not just represent a biomarker of disease. So here are protein G immunoprecipitates from kidney biopsy tissue, of which we can see none of the antigens PLA2R, THSD7A, or EXT in biopsies that don't have substantial immune complexes as negative controls, such as diabetic nephropathy and arterial nephrosclerosis. However, they are seen in EXT1 cases pretty specifically, not seen in PLA2R or THSD7A membranous cases. The presence of immune complexes being eluted from biopsy tissue that are binding IgG strongly suggests that this is an antigenic target. EXT1 and EXT2 are found to co-localize with IgG within immune deposits. There is an identical distribution of staining for EXT1 and EXT2. The protein is actually a glycosyl transferase where both components are needed for stability of one another. So you frequently don't have one protein without the other. And so we have co-localization of EXT and IgG within glomeruli, similar to what we saw with NEL1 earlier. And in a PLA2R positive membranous case, there's really no appreciable EXT staining. An observation that we've seen on some kidney biopsies, and I'd be interested to know if others have had the same observation, is that EXT positive patients tend to have punched out deposits similar to the cross section of a dragon fruit, where you can see these oriented seeds that seem punched out into this white background of the fruit. In membranous lupus nephritis, you can just see that these immune complexes are punched out and studded. I'd be interested to know if others have seen that too. EXT1 and EXT2 positive membranous cases are frequently associated with autoimmune disease. Compared to other types of membranous nephropathy, such as PLA2R, THSD7A membranous, they're predominantly female, which we also see frequently in the setting of autoimmune disease, and had normal renal function and nephrotic syndrome at baseline. A second cohort at the Mayo Clinic, which was a longitudinal retrospective study, they looked at 10 years of outcomes from patients with EXT1 and EXT2 positive membranous lupus nephritis compared to those that were EXT1 and EXT2 negative. 1/3 of cases were EXT1 and EXT2 positive, and of those, 25% had concurrent proliferative lupus nephritis, and the remaining 3/4 had pure membranous. Here are Kaplan-Meier curves looking at, death of the kidney and stage kidney disease over time. And this was a retrospective study that looked at 10 years of data, so went out to 120 months. Patients with EXT positive membranous had essentially no progression to end-stage kidney disease, which surprisingly was even true when there was a proliferative component present, compared to patients who were EXT negative. So overall, EXT-associated membranous tends to affect young females with a mean age in the 30s. Patients had normal renal function and nephrotic syndrome at baseline, and a majority have a positive ANA. And of those patients, about 1/3 had a pre-existing diagnosis of lupus. However, it's important to remember, since there is membranous nephropathy in a biopsy, for patients with a positive ANA, having another one of the SLICC criteria will provide a diagnosis for lupus. So this, the presence of an EXT membranous should alert an rheumatologic workup. And there is a good prognosis for this type of membranous. The EXT1 and EXT2, NCAM1 and TGFBR3 positive membranous cases were all younger than primary membranous. We show that from EXT1 and EXT2. But for NCAM1 and TGFBR3 positive membranous lupus nephritis that we'll discuss now, patients also had a mean age in the 30s. And we would recommend EXT staining because it has a prognostic value and autoimmune association for any case of PLA2R negative membranous nephropathy. And you can stain for EXT1 or EXT2. There is no need to stain for both, since the pattern should be identical. So the next type we'll describe is NCAM1-associated membranous lupus nephritis, or neural cell adhesion molecule 1. And this was a study in our laboratory where we employed both protein G immunoprecipitation and laser capture microdissection for protein identification. So here is protein G immunoprecipitation data. We're on volcano plot on this upper right corner where there is an higher fold change and a lower p-value. We have NCAM1. This was also enriched by laser capture microdissection. So you can see there are many more proteins by laser capture microdissection, and that is because by protein G immunoprecipitation, you're just eluting immune complexes from the glomeruli, rather than enriching for all glomerular proteins. NCAM1 overall is an immunoglobulin superfamily cell surface glycoprotein. Its role is to control expansion of T cells and dendritic cells. It also has a role in neural development, and it's expressed in the brain, in immune cells, and in podocytes. And in immune cells, that includes both lymphocytes and dendritic cells. NCAM1 was found to co-localize with IgG within glomeruli, as we saw earlier for EXT1 and EXT2. So we see an overlay for both IgG and NCAM1 staining, and there was no significant staining for NCAM1 in other types of membranous, including PLA2R positive membranous. NCAM1-associated membranous lupus nephritis can have a concurrent proliferative component, similar to EXT positive membranous. About 1/4 of cases overall had a proliferative component, such as endocapillary hypercellularity, crescent formation, or other manifestations. And the pattern of IgG staining by immunofluorescence included both glomerular capillary loop and mesangial staining. To find the frequency of NCAM1 overall in membranous lupus nephritis, we looked at 220 consecutive membranous lupus nephritis cases, performed paraffin immunofluorescence staining, where cases of 2+ or greater were considered positive, and overall 6.6% of membranous lupus cases were NCAM1 positive. A group at the Mayo Clinic, so this was described by Bobart et al., looked at NCAM1 in idiopathic membranous, of which is seen in a much lower frequency of cases, but can be seen in about 1 to 2% of idiopathic membranous nephropathy biopsies. By Western blotting, running an NCAM1 recombinant protein under non-reducing conditions, there was reactivity against NCAM1 from patient sera, but not by PLA2R positive membranous serum controls. Additionally, this was seen by a cell-based indirect immunofluorescence assay. As we saw earlier for NEL1, you use the patient sera as a primary antibody to react against a cell line overexpressing NCAM1. Anti-human IgG is used as a second antibody, a secondary antibody that's conjugated to a fluorophore and can be examined by immunofluorescence. NCAM1 autoantibodies were also detected by indirect immunofluorescence assay from this technique. You have overexpression of NCAM1 reacting with an NCAM1 antibody, but not a vector control or the cell line itself. NCAM1 patient sera was found to react, but not PLA2R, THSD7A, or EXT controls. given that NCAM1 is overexpressed in the brain, it's possible that there could be a link between nephritis and neuropsychiatric lupus by this antigen. NCAM1 expression is known to be high in cerebral cortex. In patients who have ischemic stroke, in the reactive astrocytes in that ischemic penumbra, there is high NCAM1 expression. And in epileptic patients, NCAM1 levels are increased in the cerebral spinal fluid following seizures. Overall, NCAM1-associated membranous affected predominantly females with a mean age of 34, had normal renal function, and 40% had neuropsychiatric manifestations. This is compared to 9% of overall lupus cases, so this could be enriched. And neuropsychiatric lupus includes seizures, cerebritis, or psychosis, so some more significant neurologic manifestations. We have several unanswered questions about NCAM1, and the discovery study only included 20 patients. And so we do not yet know the mechanism through which anti-NCAM1 antibodies deposit in the subepithelial space. It could be due to circulating immune complexes. There may be insight to immune complex formation, or because NCAM1 is expressed in podocytes, this could serve as a primary podocyte antigen. While anti-NCAM1 antibodies could be detected by Western blot or an indirect immunofluorescence assay, serial studies have not been performed yet to identify if there is an antibody titer that is a surrogate for disease activity, if the antibodies correlate with proteinuria, or they correlate with lupus disease activity, such as by the SLICC or BILAG indices. If that is true, this could potentially be used for monitoring treatment and therapy response. But further studies are required to know if there really is an association with proteinuria, as there is established for PLA2R positive membranous. It's also really unsure if there is a true association with neuropsychiatric lupus. So while there is an enrichment with 40% of NCAM1 positive patients having a pre-existing diagnosis of neuropsychiatric lupus, this requires further studies for further workup. And it's possible that neuropsychiatric manifestations can occur after nephritis, or nephritis being one of the early manifestations of which has been seen in some lupus patients. And if it is a true biomarker, perhaps it can monitor activity for both parts of the disease. So the next membranous antigen is transforming growth factor beta receptor 3. And so this was a study that we did in our lab in collaboration with UAMS and Dr. Beck at Boston Medical Center. And I'm just displaying the data a little bit differently, but this is the same techniques used before. So protein G immunoprecipitation to elute immune complexes from kidney biopsy tissue showed several unique peptides in TGFBR3 positive patients and not in controls. When you have a protein target, you want to see that the peptides of interest are specifically expressed, as well as that there are multiple, and that which can correspond to higher sequence coverage, but depending on the size of the protein and location of the epitope, may not always have high levels of sequence coverage. So multiple peptides were seen in both protein G immunoprecipitation and laser capture microdissection, and most of these are the same peptides. TGFBR3 stained in an expected granular capillary loop pattern within glomeruli. Deposits tend to be chunky. Some of them actually looked like an infection-associated GN, where there's these large subepithelial pump-like deposits. TGFBR3 had co-localization with IgG within glomeruli. That was not seen in EXT membranous or PLA2R positive membranous cases. And TGFBR3 also lacked IgG4 predominance. And while this case has no IgG4 staining, some do. Half of TGFBR3-associated membranous cases have a proliferative component. So here on the upper panel, we have a case of TGFBR3 membranous with some thickened capillary loops, mesangial expansion, and frequent formation of holes on a Jones-Silver stain. Below, there is a TGFBR3-associated membranous case as well, but has concurrent proliferative changes, including endocapillary hypercellularity and crescent formation. While EXT1 and EXT2-associated membranous is associated with a good renal prognosis, it's possible because of the higher level of proliferative activity that this may have a worse renal prognosis, although further studies are needed, and this cohort only included 17 patients. Tubular reticular inclusions were seen in some biopsies. As you can see in other cases of membranous lupus nephritis, it's not necessarily specific to TGFBR3. And overall, in screening the same cohort as NCAM1 with 6 months of consecutive cases, the frequency of TGFBR3 in membranous lupus nephritis was 5.5%. Histologic features of TGFBR3-associated membranous, EXT1 and EXT2 membranous, as well as NCAM1-associated membranous, mirrored those findings that were seen by the earlier study in the Columbia group, where there was frequently expression of more immune reactants than just IgG and C3. So there could be IgA, IgM, and C1q positivity. A good number also had full house immunofluorescence staining, about half of cases. Mesangial deposits were nearly ubiquitous for these 3 types of membranous, and subendothelial deposits are not infrequently seen. As an overview, TGFBR3-associated membranous, similar to NCAM1 and EXT, affected young females of the mean age in the 30s, had normal renal function and nephrotic syndrome at baseline, and this antigen was highly associated with autoimmune disease and lupus. Antibodies, unfortunately, could not be identified circulating in the serum. This was similar to EXT-positive membranous. For TGFBR3, there is expression of podocytes. And so here is human glomerular extract with an anti-TGFBR3 antibody, just showing that it is present in the human glomerular extract. And Triton X100 enriches for membrane fractions, so there is enrichment there. When immunoprecipitating with serum, TGFBR3 positive cases did not show serum immunoprecipitation. However, in utilizing PLA2R positive membranous as a control, there was positivity for PLA2R. And this work actually came from Dr. Beck's lab, who did a similar study for PLA2R positive membranous. We also could not see reactivity against TGFBR3 recombinant protein with reducing or non-reducing conditions, or through indirect immunofluorescence assay. So an unanswered question is, why can't we detect antibodies? And this is true for both EXT and TGFBR3. We think antibodies exist, but we haven't yet identified in serum. It could be that there are multimolecular immune complexes. The target proteins may have undergone glycosylation or other post-translational modifications. They could be opsonized by complement, have in situ immune complex formation where there is local aggregates of immune complexes that may have low titers actually in circulation. There could be low avidity, so the antibody may just fall off of its target antigen in the assay as the binding is weak. Or the enriched proteins could serve as biomarkers and really not be true autoantigens, as you need an antibody to call something an antigen. But because protein G immunoprecipitation from all of these have been able to elute antibodies from tissue, I do believe these are all antigens. We just need to work harder to identify antibodies in the serum. Here's another type of membranous nephropathy that's been very recently described. It's associated with chronic inflammatory demyelinating polyneuropathy and is Contactin-1. Contactin-1 was identified through serum immunoprecipitation with human glomerular extract, but interestingly, also with brain extract. And this is a disease associated with a neurologic condition, chronic inflammatory demyelinating polyneuropathy, and had band of the same molecular weight. Co-localization of Contactin-1 and IgG was seen within glomeruli. These are IgG4 dominant antibodies. And in T's nerve preps, there is co-localization of IgG and Contactin-1 that was not seen with PLA2R positive membranous cases. And you can see Contactin-1 is still expressed at the synapse. It's just that there was no co-localization with the antibody. So the group that did this study had a very elegant design. They had 1,500 patients with chronic inflammatory demyelinating polyneuropathy or acute polyneuritis for which they had serum for, so very large cohort for rare disease. These patients were predominantly male of older age, so kind of an opposite demographic from what we were describing earlier. And 1,100 to 1,500 patients were found to have Contactin-1 antibodies. 5 of those 11 developed membranous nephropathy. So having circulating Contactin antibodies was associated with development of the kidney disease. This next entity is not a form of membranous lupus nephritis, but we believe it has an autoimmune etiology, so I'd also like to bring it up here, is membranous-like glomerulopathy with masked IgG kappa deposits, or MGMID. So on light microscopy, MGMID shows mesangial proliferation, as well as thickened glomerular capillary loops of which you can see formation of spikes and holes on silver stains. There can be associated proliferative changes, which occurs in about 1/4 of cases, as you can see a case of the cellular crescent. Overall, chronicity can lead to segmentally sclerotic lesions as well. And by routine immunofluorescence, there is no staining for IgG as you would see by membranous nephropathy or with immunoglobulin heavier light chains. However, ultrastructurally, there's presence of these subepithelial and intramembranous deposits. Mesangial deposits are also quite frequent. Okay, so where are the immune complexes coming from? We don't see them by frozen immunofluorescence staining. So the next step is to perform paraffin immunofluorescence when you want to look for masked immune deposits. So you take the FFPE tissue and you expose to pronase. It will open up epitopes for antibodies to bind, and in this case, IgG and kappa light chain light up, but not lambda light chain. And so this fits with the definition membranous-like. It's a glomerulopathy with masked IgG kappa deposits. And overall, there was no significant staining for IgG by routine immunofluorescence, but bright staining by paraffin immunofluorescence with only kappa and not lambda light chain in the discovery cohort of 14 patients. And this was, the study was performed at Arkana by Dr. Larson and others back in 2014. But more recently, laser capture microdissection was used to determine if there's an antigenic target in this disease. And in cases of membranous-like glomerulopathy with masked IgG kappa deposits, their serum amyloid P was identified as a target antigen and colocalized with IgG within glomeruli, but not with PLA2R positive membranous cases. SAP staining was then used to look at a variety of different autoimmune kidney diseases or immune complex mediated kidney diseases and did not have appreciable staining. Overall, patients with membranous-like glomerulopathy with masked IgG kappa deposits were predominantly young females, had frequently had preserved renal function and nephrotic range proteinuria, and many of them had a positive ANA. So these were similar features and demographics as we've seen in membranous lupus nephritis, although is not a form of membranous lupus nephritis. Currently, this is an orphan disease, and there's really not enough data to know the optimal therapy and the impact of outcomes, and this really necessitates a larger study at this point. From a study of 41 patients, and the study was also performed at Arkana, there was no relationship identified between immunosuppressive therapies. 56% of patients achieved partial or complete remission, but 44 progressed or went on to end-stage kidney disease. This disease can recur in a transplant, so further studies are needed. And we believe that this represents an autoimmune disease with a reaction against serum amyloid P, rather than representing a paraprotein-mediated disease, as there are IgG kappa-restricted immune deposits on biopsy. But SAP actually performs a direct protein-protein interaction with IgG1 kappa, which could explain this light chain restriction. Some take-home messages are that membranous lupus nephritis is a leading cause of nephrotic syndrome with patients with lupus. It can occur in addition to proliferative lupus nephritis, and new biomarkers have been identified in lupus, including EXT, NCAM1, and TGFBR3. These could have significance for prognosis, as we saw EXT1 and EXT2 had a great prognosis, even when there was a proliferative membranous lupus nephritis. NCAM1 antibodies could be potentially utilized for treatment monitoring, and hopefully in the future we find EXT and TGFBR3 antibodies in serum as well. And further studies are really required to determine if biomarkers will serve as or if the antibodies will serve as biomarkers for disease. Having expression for any of these three antigens could alert you to search for an underlying autoimmune disease and can distinguish potential disease etiologies. May also define subtypes, such as maybe NCAM1 has an association with neuropsychiatric lupus. Potentially, there are also differential outcomes. So I'd like to thank you for your attention. I'd be happy to answer any questions, and I'm really glad to be here today, and thanks all for listening.
Well, thank you, Dr. Caza, for that excellent update on membranous lupus nephropathy. And there's a lot of questions within the chat, and so I'll try to organize them the best that I can. So there's a few questions and some discussion about the possibility of antibody switching, that if that occurs, or if on repeat biopsies you see the same consistent staining, or if the staining types can change.
So as far as class switching, it has been shown in idiopathic membranous early in disease, you could have an IgG1 subclass that then will cross switch to IgG4. I'm not sure about these antigen types, and because we've seen early membranous cases where they have stage 1 immune deposits ultrastructurally that have more than one subclass, I don't think so, but it still isn't super early in the disease when you can, identify those large electron dense deposits. Also, IgG1 and IgG3 both bind complement and fixed complement, and so those are frequently more seen in lupus than in idiopathic membranous. I'm not sure if I answered the question. Does that help?
I think so. Do you ever see cases that say stain for EXT1, but then stain for a different antigen later, or is it consistent, or can they lose staining?
So Dr. Miller and Dr. Sharu actually explored this recently with EXT and NCAM1-associated cases. Most of them will have the same membranous type at follow-up, but there were cases that had lost EXT expression. for which when repeat biopsies were performed, there was differential staining. So yes, and I also think that there could be multiple antigens present, as in the setting of lupus, patients form all kinds of autoantibodies. So as we learn new targets, I wouldn't be surprised if some go together, at least more than the frequency we see in idiopathic membranous.
Great. There were also some questions regarding the positivity or negativity on the serum testing for some of these and the clinical significance of either.
I really think there's antibodies in serum. We just didn't find them yet. But yeah, today there hasn't been EXT antibodies or TGFBR3 antibodies in serum. If people have ideas, please chime in and let us know if you have any creative solutions to finding these. Perhaps we need new techniques or ways to expose those epitopes that we haven't tried yet. But I think it'll be a while before we know if these will serve as biomarkers, because you need very many serial serum samples to see is there any correlation with proteinuria. Do you see an increase in antibody titers prior to recurrence of disease? These studies will take a long time, and could be done for NCAM, except there are very few patients that have been identified with this disease. So hopefully over time, we'll know if that can serve as a biomarker. And by then, hopefully find antibodies for EXT and TGFBR3 as well.
Yes, it looks like Dr. Glassock has a few comments that circulating immune complexes formed in antigen excess may preferably localize to the subendothelial space. And in this circumstance, there are no free binding sites available to detect the antibody. And that intramolecular epitope spreading is common in primary membranous, but unknown in membranous lupus nephritis. There was also a question about the on electron microscopy, if the characteristics of the deposits on electron microscopy could give clues to the potential nature of the antigen, like you mentioned the dragon fruit, and also if the dragon fruit pattern, how that compares to the microspheral variant of membranous.
We haven't seen cases of EXT positive membranous with microspherular deposits yet, but it's such a rare ultrastructurally finding in membranous, so I can't tell you that it's not there. We haven't looked, to be honest with you. Perhaps the disease course, it could represent when it's detected in the disease course, because you have these intramembranous punched out deposits, and patients could be biopsied earlier and have small subepithelial deposits, but perhaps it reflects the clinical presentation that could maybe more insidious than an abrupt onset of nephrotic syndrome. That's a complete speculation, but perhaps they're not coming to clinical attention until later in the disease.
Okay, great. And regarding the good prognosis of EXT1 and 2, is there any thoughts as to why this might correlate with a good prognosis, or are those studies in progress?
To be completely honest with you, I don't know, but I do believe other studies are in progress. This work has been done by work by Dr. Seffi's group at the Mayo Clinic, as well as an international group led by Dr. Ronco, who published very similar findings in KI reports, I believe. So the work has been replicated among multiple cohorts by this time. So I definitely believe it's associated with a good prognosis. Why? I don't know.
And there's a question, is NCAM1 associated with small cell lung cancer cases?
So actually, we did look at these antigens in malignancy-associated membranous. This is another area of interest. We found that NCAM1 is enriched in malignancy compared to other antigens, and we only found a single case of NCAM1 membranous that in a patient with malignancy. So I don't think this is a common association, but I can see where that comes from, because NCAM1 is CD56 and it's known to be increased in some cancers, both hematologic and solid tumors, but we haven't observed that association clinically yet.
Okay, great. I think that pretty much sums up all the questions in the chat. And we're at the hour, so let me just see what here. Oh, sorry, there was one last question. Over time, the histological pattern can change, which is the reason why we do biopsies in the event of new. So, see, I think this question's asking,
oh, I'm reading it. I bet it's flares.
yeah.
Event of new flares.
Yeah, flares, I think.
And then they're asking, are other autoantibodies at play? That's possible, and I don't think that serologic monitoring is going to replace kidney biopsy anytime soon. I do hope that it will play a role in treatment. It's been shown in lupus that you can have a new onset of additional antibodies in disease, and patients with a positive ANA later can develop anti-RMP or anti-Smith or other types of antibodies later on. So it's definitely possible, and I don't have the data to suggest, at least with these antigens. Lots of questions to explore, and hopefully some of you are interested in exploring those as well. There's a lot to be learned about membranous lupus, and so many of them don't even have an antigen type yet. So.
No, thank you very much, Dr. Caza, and we appreciate the fantastic talk and all the new possibilities for membranous lupus nephritis. And so I think with that, we'll end the session. Thank you.
Yeah, thanks for you, Dr. Bisnet, and for you all for listening. Please feel free to reach out to me by email or Twitter. I love to talk about lupus.